Okay, start the second video on, let's talk about suctioning. Suctioning should be done when adventitious breath sounds are heard, which indicates that there are secretions present, such as when your patient has an endotube or tracheostomy. You'll hear gurgling sounds. So you're going to use an aseptic technique, wear mask and goggles. You'll advance the catheter down to where you feel resistance. Usually, or a lot of times, the patient will cough, depending on their sedation level or their neurological function. And when they cough, that's when you know you've hit bottom. So you can then start suctioning on the way out. And you want to limit that suction to 10 or 15 seconds, and pass the catheter. Do only 3 suctions as a maximum. Sometimes that first suctioning will take the secretions out that you wanted to remove. Sometimes it takes an additional or a third pass. Each time you should make sure you oxygenate for 1 to 2 minutes before and hyperoxygenate 1 or 2 minutes after, so to avoid hypoxia. Oxygen administration, generally speaking, want to make sure that O2 saturations are greater than 90%, ideally above 95%, except for those who are COPD, who have COPD, and we want to keep them in the low 90s. You can use a simple face mask. General nasal cannula you can use as a nursing measure, up to 2 liters as a nursing measure. After that, you have to have an order. Simple face mask. Non-rebreathers deliver between 60 and 90%. Partial rebreathers have a attached bag, can deliver high oxygen concentrations. That Venturi mask has a dial on it, so you can dial that in to the exact O2 level that you want. CPAP and BiPAP both, most of the time you bleed oxygen into those as well. It's easy to measure oxygen sat under most conditions. Use pulse oximeter. It's non-invasive. You can use the finger. I like to use a ring finger. I find that one works best for me. You can use a toe, an earlobe. I see that once in a while whenever somebody has poor circulation, or their hands are really cold, or you can't get an accurate reading on their fingers. You can a lot of times use their earlobe. Make sure they don't have any nail polish. Make sure it's removed because the pulse oximeter won't be able to read it accurately. Tracheostomy care. Make sure you use aseptic technique. Clean disposable inner cannula with hydrogen peroxide and then rinse it with sterile saline. A lot of times you'll use a 4x4 gauze. After the inner cannula is inserted, to catch secretions. Under respiratory isolation, you have to use a mask. Client needs to use a mask if they're leaving the room. Proper use of inhaler with spacers. Have the client exhale completely. Grip the mouthpiece in the mouth. Grip mouthpiece in the mouth only if the client has a spacer. Otherwise, keep the mouth open to bring in some volume of air with misted medication. While inhaling slowly, push down firmly on the inhaler to release the medication. They can also use a bronchodilator. So if they have a bronchodilator and a steroid order, make sure you use your bronchodilator first. That opens up the airways so that then after that, the steroid can be administered and it gets into the lungs a lot more effectively after the passages are dilated. Wait at least 1 minute between puffs. And make sure after they inhale a steroid that they perform oral care. At least rinse your mouth out with water, and that prevents fungal infections such as thrush, which can manifest as kind of a red sore mouth. Look and listen to your patient. Look at them, listen to them. If breath sounds are clear and the client is cyanotic and lethargic, then they're not getting enough oxygen. If you're administering over 4 liters of oxygen, make sure that humidity is used. There'll be a humidity canister for, like, if you have nasal cannula. There'll be a canister in the air, and they need to bubble through that water or saline so that it's effective. And next we'll talk about laryngeal cancer, which we covered in this module. Often due to prolonged use of alcohol and tobacco, either individually or together. Other contributing factors: vocal straining, chronic laryngitis. There's genetic factors that have to be taken in consideration. Industrial exposure, such as carcinogens, agricultural exposures, farmers, coal miners, petroleum industry, construction industry, all of those have a higher incidence. Also nutritional deficiencies such as riboflavin. Men are 8 times higher than women. Diagnosed usually between 55 and 70. Earliest sign is hoarseness, or change in vocal quality that lasts more than a couple weeks. Medical management can include radiation, along with chemo or surgical removal, and laryngectomy that we talked about. They a lot of times will perform an MRI. They can use a laryngoscope. Assess for color changes in mouth and tongue. With cancer of the larynx, the tongue and mouth often appear white, gray, dark brown, or black. It may appear patchy. Assess for dysphagia, dyspnea, cough, hemoptysis, weight loss, neck pain radiating to the ear, and large cervical nodes, and halitosis in later stages. Chest x-rays, neck x-rays, CTs, biopsies. Provide preoperative teaching for the postoperative phase. So do this ahead of time. Explain how and why suctioning will take place. Let them see the equipment, get familiar with it, so that when they're approached, they're familiar with it and they're not scared by it or freaked out, anxious. Plan for acceptable communication. Figure out whether they might want to use a dry erase board at first, or paper and pencil, or and explain to them the availability of the electrolarynx and the esophageal speech. And we talked a little bit about this esophageal. It's a technique. Not everybody can master it. It's kind of like where you trap the air down and then create a pressure, kind of like when you're creating a burp, and then the release of that vibrates the esophagus and can create some sounds similar to speech. Postoperative care. Keep your communication simple. Keep the call light in reach. Keep the questions short, yes or no questions. The client's probably going to grieve, or the high probability they're going to grieve about the alteration of body image. They could have surgical incisions, as well as the problem with their speech. Assess their respiratory rate every 1 to 2 hours. Keep them in a semi-Fowler position at all times. Keep laryngeal airway humidified at all times. Auscultate lung sounds every 1 to 2 hours, every 2 to 4 hours. Client may retain secretions, suction excess secretions from mouth, and ostomy as needed immediately after surgery. Provide ostomy care every 2 to 4 hours as needed. Ostomy care involves cleaning the inner cannula, suctioning, and applying clean dressings. You may need to administer tube feedings, as they will be NPO, usually 7 to 10 days. Encourage ambulation as soon as possible. refer to speech rehab. Referral for speech rehab so they can learn how to use the artificial larynx or esophageal speech. Make sure their environment is not too dry. Humidification might be required. Always make sure you keep suctioning equipment at the bedside for new and chronic tracheostomy clients. You never know when you're going to need it in a hurry. All right, that's all I got for you. We'll see you on Monday.